Welcome to the SmartEducation podcast, episode 2. Today we have Tzvika Greenbaum from Israel here with us. Welcome, Tzvika.
Thank you very much.
You just arrived?
Yeah, just arrived to Belgium, and I love to be here again.
Yeah, because it's not the first time. I know you already since the last, I think it's more than a year already that we see the first time we saw each other. But for physios out there who don't know Tzvika Greenbaum, can you maybe tell a little bit about yourself, about your work, and about your specialty, which is temporomandibular disorders? That's why we asked you here.
Yeah. So I graduated on 2004 in Haifa University in Israel, and then after 2 years I headed to South Australia to a master degree, a combined master degree of sports and musculoskeletal rehabilitation. And there in Australia I started to really fall in love with the upper neck and the headache topics.
And the temporomandibular joint as well, of course, which is...
Yeah, and later on what happened when I came back to Israel and started to treat patients, I could see that plenty of them are complaining as well as on masticatory dysfunction, clicks, pains around the jaw. So that I started to understand that without combining this whole topic of upper neck headaches and masticatory system, I will not be able to help most of them. So then I started to get into it and to see more and more patients until the stage of getting to a supervisor in Tel Aviv University, a dentist named Dr. Winocor. He's quite a famous dentist in Israel. And we decided to explore together the connection, the clinical connection between upper neck dysfunction and temporomandibular joint disorders. Yeah. And he started to refer many patients to me and also his colleagues.
And that's how you not only fell in love with the TMD, but you almost are married with it because you're doing a PhD now on...
So
can you maybe tell a little bit more, because I'm going a little bit too fast maybe, but we want to know, especially on the subject of your PhD, and maybe you can tell us about the results already in advance, because it's not already written.
It hasn't been published yet.
It hasn't been published yet.
We only published one promo of the PhD. It was 3 years ago in manual therapy. That was our first small study where we assessed the flexion rotation test. This is the upper neck mobility test of temporomandibular disorder patients. And there we could actually notice that they are very limited in their upper neck compared to healthy controls. That was our first study. And it was kind of a preliminary study for the PhD. And then we decided that we actually want to characterize the neck performance and pain parameters of temporomandibular disorder patients. Temporomandibular disorder patients are quite wide, because they have not only one diagnosis, they have 3 main diagnoses. So one is the pain-related temporomandibular disorder, which is mainly muscular problem. The second one is a disc displacement problem, so it's an intra-articular disorder. We have a few of them, 4 of them, which I will not tell you right now about all of them. And the third one is the degenerative joint disorder. So that's the temporomandibular disorder patients that are you can actually categorize them into three main categories. The main category that you will see in clinic is the pain-related TMD. So the patient that complains on pain is mainly muscular disorder.
So myofascial related pain.
It's a lot about stress, clenching, grinding the teeth, and it's very much related to upper neck disorders. So actually in the study we found a prevalence of up to 30% of these patients have a comorbidity of cervicogenic headache. Cervicogenic headache is it's not very rare diagnosis, but only 4% of the overall population can be diagnosed with cervicogenic headache. If you go to the temporomandibular disorder patients, for the pain-related population, you will find up to 40%. So that's very high. So that tells me as a therapist that almost every second patient with TMD may have cervicogenic headache as well. If we don't understand it and if we don't assess it and if we misdiagnose it, we may not be able to help this patient because until we start treating their neck, they may still having pain in their face that is related to the neck. Because the classical pattern of pain for cervicogenic headache patients is a fascial pain and not a headache. So it's associated. It goes together. So that's one of the main findings of the PhD project.
Yeah, really interesting. And I think you go into that on the courses you do here in Belgium on the TMD, which are actually very successful. There's a lot of interest on that topic, which is good because then we get to see you even more. Maybe you can tell us a little bit about the course outline that you made for this course. You have different aspects that you touch on. And subsequently, maybe you can tell something about, in your experience, if you do a course like this, what is your thoughts about the quality of the physios that you are teaching, for example, here in Belgium? And what do you think is lacking of knowledge for them to fail sometimes rehab? Where are the pitfalls for physios when treating temporomandibular disorders? Maybe that's 3 or 4 questions in one sentence.
Yeah, but I'll do my best. The course outline is, we were starting from background, we're starting from pathophysiology, epidemiology in the first day, and then we are moving on to categorizing the TMD patients, so how to diagnose them, evidence-based, of course. We
talked about that just before.
Before. So we're actually trying to decide the patient in front of me is suffering from pain-related TMD, intra-articular TMD, or degenerative joint disease. After we understand that, then we can ask ourselves another important question: how is the neck involved in this presentation? Because many times, as I said before, it will be involved. So that's another question. First of all, what kind of TMD, and then plus or minus an upper neck disorder. And then we are quite ready to start treating the patient after we understood that. Of course, another question is if there is a cervicogenic headache or not. So upper neck disorder is not always going with typical cervicogenic headache, but if it does, then we need to treat the cervicogenic headache. And then we start to develop and practice with the clinical approach of treating pain-related TMD patients, which is mainly finding their contributing factors. It's very important because it's not only treating their jaw when they have pain, it's about their habits, the masticatory habits, their posture, their physical activity, their stress level, their sleeping quality. This is a very wide kind of approach. Whereas the intra-articular patient is more mechanical. So intra-articular is something wrong mechanically inside their jaw, inside their joint. So we need to understand what exactly is wrong there. And then we need to manage it right without creating too much inflammation, for example, in specific stages. So it's different. Of course, we look with them as well on contributing factors, but not as much as pain-related TMD. So for me, it's a different kind of management. Whereas the degenerative joint patients, they are usually older, and usually it's gradual onset, and we treat them, always I give this example, the same like we treat OA of the hip, for example. So we think about improving range of motion gradually and then activating the joint and preventing deterioration of muscular activity. And it's a long term, so it's a kind of a marathon. We are trying to manage them for in the long term.
Yeah.
So it's 3 different approaches that we develop, but we cannot approach it until we understand or until we have the assessment of what they are having, or what is their main problem. Sometimes they will have a combined problem, and then it's not very simple. And then we need to decide which of their problems we want to approach first. For example, if you have an intra-articular problem, but also a pain-related TMD, I would start with the pain-related component. And then when you have less pain, you suffer less, maybe then we can approach your intra-articular problem with exercise, with manual therapy, with maybe with some oral appliance that the dentist will prescribe.
Yeah.
And of course, the neck. The neck, if the neck is there, if the neck involved in the presentation, I would most of the time start from assessing and treating the neck. Because from my experience, if the neck is not working well, it will be very hard to get better with pain-related TMD, because that's basically where the head and the mandibular are standing on. So you want to improve first. It's the same like if you have a low back pain patient, you want to look what is going on with his hips and his pelvis. Otherwise, you cannot approach. It's
always combined approach. So it's fair to say that assessment is very important. Clinical reasoning is a very important part of it. And the last part of my question was, what do you think that in your experience, since you treat a lot of TMD and cervical related pain, headaches and complaints, where are patients who come to see you, probably they first saw another physiotherapist. And what do you think where the physiotherapists fail in rehab? Why are they not succeeding with certain categories of patients? And which categories are maybe the most difficult to treat?
Well, I think with the pain-related TMD, as very similar to other chronic pain patients, I think sometimes we don't listen to them enough. Sometimes the answer, many times the answer is there. The patient knows the answer. Maybe he doesn't know that it will help him, but somewhere inside of him, the answer is there. And we tend to go and treat them as like a mechanical patient. So we go to their trigger point, which is good, which is all right. But before we understood that they are clenching their teeth, before we understood that their sleeping is really bad, before we understood that they are really stressed and all they need is just someone to relax them, before we understood that they are not physically active. And pain-related TMD are quite complicated patients because they tend to have some other problems as well, according to research. They tend to have some other pain problems usually. So they may have some maybe back pain, headaches. The comorbidity is really high in this population and tend to be quite stressed. They have a higher level of anxiety and depression, for example. So
you think physiotherapists are not seeing that enough, or
not enough? Not enough. I think these patients, the pain-related TMD patients, are maybe even more delicate and sensitive than even chronic low back patients, because I see it's mainly female. So the vast majority of TMD patients are around 70-80% female, and they are in the fertility age. So they are young moms that are quite stressed in their life. They have young kids. They still need to go to work. And sometimes we just miss that. And this stress comes to their jaw. So somehow they have some somatic phenomena of clenching the teeth, for example, because of the stress. Of course, we're not psychologists, but we can teach them some techniques to, first of all, we can demonstrate them that that's the problem. Sometimes they don't understand that they're clenching the teeth.
So we need to acknowledge that it's a multifactorial problem.
And give them solutions. Give them somatic solutions, not the psychological solutions. Yeah, also, but mainly if you clench your teeth, let's teach you techniques to avoid that. Whenever, let's bring it to your awareness, and then you may avoid it, and then you may see that you have less pain, and then you may be more relaxed, you feel more in control, and then the problem is not very bad as it was before. Whereas with the intra-articular patients, the main mistakes is, first of all, misdiagnosing it, or missing it and thinking it's maybe an osteoarthritis or something like this. Or sometimes you misdiagnosing it with muscular